Okay, in the interest of time, we're going to go ahead and get started and people can pop in as we go. Dr. Patricio Fernandez is presenting our lecture today, and it is on recognition and stabilization of cardiac patients pre-transport. Dr. Fernandez graduated top 10 in his class in med school at La Salle University in Mexico City. He did his pediatric residency at Driscoll Children's Hospital in Corpus Christi, Texas, Texas A&M University. He did his neonatology at University of Kentucky in Lexington, Kentucky, and an ECMO fellowship at Children's National Medical Center in Washington, D.C., and his pediatric cardiology fellowship at Johns Hopkins University and UCSD Medical Center. Interventional pediatric cardiology at the Hospital for Sick Children in Toronto, Canada. He is an American board certified in pediatrics, neonatology, and pediatric cardiology. He has 25 years of experience and has worked in Mexico, Canada, and the United States. His areas of expertise are neonatal heart disease, persistent pulmonary hypertension of the newborn, high-frequency oscillatory ventilation, and minimally invasive surfactant administration. So let's all give a warm virtual welcome to Dr. Patricio Fernandez.
Thank you, Denise. It's a pleasure to be here.
So just a little housekeeping before he gets started. Please make sure you're in a quiet space where you can focus. Please keep your microphone muted so that the background noise is not distracting. Keep your camera on if you are a Rady employee and you want to get CE credits or have applied for education time for this. The intention of this education is to be interactive. If you have a comment, you can raise your hand or write it in the chat box, and we might call on you at that time, or we might ask you to wait until the end. If you are called on, unmute your microphone to speak and then mute it again when you're done. Listen closely during the section for answers during the slides, and please write down any of the questions that you'll have during the presentation or type them into the chat box for the end of the session. Dr. Fernandez will try to address all of the questions at the end of the session. Please take the time to change your name on the video to your full name for attendance purposes. At the end of the course, there will be a QR code and a link to a post-educational survey. You will need to have a cell phone or a tablet with camera capabilities available to use the QR code. Use your camera to open the QR code link. If you are on a computer without a phone available, you can copy the link into your browser. After you complete the survey, the CE will go directly to your email. Rady likes to block links and attachments, so I suggest you enter your personal email for the CE to be sent to, and I won't use it for any other reason. This information will be inside a password-protected application and deleted as soon as the surveys are collected for our CE purposes. If you do not complete the survey, you will not receive CEs for the course. If you have trouble with the QR code or link, please email me directly and I will provide my email and the QR code at the end of the session. This class will provide one CE. It's a nursing CE, but it's good for both nursing education and it qualifies for the California license and NBRC requirements for the RTs as well. This class also qualifies towards your neonatal pediatric specialty certification requirement. If you're a physician in attendance, please fill out the survey at the end as well to provide some constructive information back to Patricio. I'm going to stop sharing at this time and allow Patricio to share his screen.
Okay, so today we're going to talk about critical congenital heart disease, a pathophysiologic approach pre-transport, and I hope it's going to be helpful to everybody. The old classification was very simple and was developed by Dr. Helen Taussig at Johns Hopkins Children's Hospital. Was basically acyanotic congenital heart disease. You have two possibilities: increased pulmonary blood flow or decreased pulmonary blood flow. And the cyanotic part of congenital heart disease that with increased or decreased pulmonary blood flow. But now in 2022, we need to have a more functional classification of congenital heart defects. So we have this classification now that it talks about critical congenital heart disease, and we divide that into groups: ductal dependent and not ductal dependent congenital heart disease. And critical congenital heart disease is defined as any critical form of congenital heart disease that have an additional instability during the perinatal transition period and often required any cardiac intervention during the first hours after delivery for stabilization and survival. We know that there are 11,000 cases a year of these critical congenital heart disease, and 6,000 of them are ductal dependent. So we need to know that critical congenital heart disease is surgical. There is no way around that. So we need intervention and we need surgery within the first few hours of life to stabilize and possibly save this patient. So we have different presentations: cyanosis in patients that has total anomalous coronary venous return, tetralogy of Fallot, truncus arteriosus, critical pulmonary stenosis, tricuspid atresia, and pulmonary atresia, or transposition of the great arteries. You can have state of shock in babies with left-sided obstructive lesions like hypoplastic left heart, aortic stenosis, coarctation of the aorta, or you can have later in life the develop of congestive heart failure in babies with PDA, ASDs, or BSDs. The timing of surgery is essential. If you have a patient with obstructed total anomalous coronary venous return, you need to make the diagnosis fast. In this case, this is an intradiaphragmatic patient with severe obstruction with massive pulmonary edema. So you need to recognize that, stabilize the patient as soon as possible, and transfer the patient to a cardiac center. If you are in a community hospital, that's where usually these babies are born. And the surgery should be done within hours to be able to save the baby. If you have a baby with detransposition of the great arteries, you need to transfer the baby as soon as possible so the baby can get the arterial switch operation within the first week of life. As we know, we need to do that because if the PVR drops too much, then the left ventricle will not be ready to support the systemic circulation. If the baby has hypoplastic left heart syndrome, then we need to do the hybrid stage 1 palliation or the stage 1 Norwood within the first 1 to 3 days of life, ideally, or during the first week of life, in order to be able to get the better surgical results. In contrast with the common AV canal, that is a critical congenital heart disease, but is not ductal dependent. These babies will develop congestive heart failure over time. You don't need to wait for the symptoms. They need to be repaired electively in between 2 to 4 months of age. And they usually get very good results. As you can see, the majority of them have Down syndrome. So critical congenital heart disease in the US, we have 35,000 cases of congenital heart disease in the US every year. We have critical congenital heart disease in 11,000 of them, and ductal dependent congenital heart disease are 6,000 a year every time. In order to understand critical congenital heart disease, we need to remember the fetal circulation. So we need to know that 1/3 of the fetal circulation go through the foraminal valley and into the lungs, and 2/3 goes to the RV and then via the PDA to the systemic circulation, giving the brain and the coronary arteries the highest oxygenated blood in the fetus. 65% of the fetal circulation comes from the RV, and 20% combined our output comes from the LV, feeding the brain. So the fetal circulation have a low resistant placenta. We have a ductus venosus, we have a PFO, we have a ductus arteriosus, and then the lungs are closed. So we have a system with a high pulmonary vascular resistance and a low systemic vascular resistance. When the baby is born, then we usually lose the placenta and the lungs expands and the ventilation starts. The ductus venosus, the PFO, and the ductus arteriosus close And then we switch to a system of high systemic vascular resistance and a low pulmonary vascular resistance. So in order to keep these babies alive, we need the ductus arteriosus. So we need to know and understand the ductus physiology. So we need to know that there are situations or factors that tend to close the ductus, like the calcium, oxygen, and endothelin 1, and factors that tend to keep the ductus open, like nitric oxide, prostaglandin, prostacyclin, and the intraluminal pressure that try to keep the ductus open. So in order to know what's going on with the ductus, in order to keep the systemic circulation going or the pulmonary circulation going, we need to understand the neonatal ductal Doppler physiology. So if you put the Doppler sample in the pulmonary artery, then you can analyze the different ductal shunt patterns. You can see here that you have a restricted left to right shunt. The PDA is closing, and the flow through the ductus is mainly during systole. If you have a non-restricted left to right shunt, then you have flow during systole and diastole, and that ductus is widely open, and probably the pulmonary blood flow in that patient is going to be good. And the oxygen saturation consequently is going to be good. Here you have a bidirectional shunt in a patient that is getting sick with pulmonary hypertension, and you can see that we have bidirectional shunt in here. In diastole is left to right, and in systole is right to left. And then in a patient with coarctation of the aorta or suprasystemic pulmonary hypertension, you see that the flow is mainly right to left. So if you have an echo machine and you can do Doppler of the ductus, then you can know what's going on in the physiology of this patient, and you can act in a timely fashion. Then the question comes, why critical congenital heart disease is not fatal in utero? Well, because we have the PDA that is open, a PFO that is open, the ductus venosus that is open, and the placenta is doing the gas exchange for the baby. So even in babies with this hypoplastic left heart syndrome, the babies are going to be very comfortable inside the mom until the baby is born. Then we need to know the timing of the closure of the ductus arteriosus, so we know how much time we have to stabilize this patient once we make the diagnosis. The median closure time of the PDA in a full-term baby is around 13.5 hours. The range is in between 7.7 to 18.7 hours. And in all the babies that are less than 30 minutes old, all the PDAs were open. No baby had a small duct. At around 2 to 3 hours of age, 80% of the babies had a large PDA, 20% had small PDA. And then by 7 to 10 hours of age, the PDA had closing 20% of the patients, and 47% of them had small PDA. So you know how much time you have to stabilize that patient before the PDA closes. So if the blood passing through the right side of the heart meets a severe obstruction and the patient has critical pulmonary stenosis, pulmonary atresia with intact ventricular septum, severe tetralogy of Fallot, or single ventricle with pulmonary stenosis or pulmonary atresia, or tricuspid atresia with pulmonary stenosis or pulmonary atresia, the newborn will be dependent on the ductus for pulmonary blood flow. The loss of the ductus will lead to severe cyanosis followed by acidosis and cardiogenic shock. If, on the contrary, if the blood passing through the left side of the heart meets a severe obstruction and the patient has a coarctation of the aorta, hypoplastic left heart syndrome, critical valvar aortic stenosis, or interrupted aortic arch, then the newborn will be dependent on the ductus for systemic blood flow. And the loss of the ductus will lead to severe hypertension, acidosis, and cardiogenic shock. So then we know that ductal-dependent critical congenital heart disease will require neonatal intervention. Ductal-dependent lesions require prostaglandin infusion, followed by a catheter or surgical intervention to replace the ductus to have a stable source of pulmonary or systemic blood flow. So in the case of pulmonary atresia, you can have stenting of the ductus or a modified Blalock-Taussig shunt to keep the blood stable pulmonary blood flow. In the case of hypoplastic left heart, then you need stage 1 Norwood with a modified Blalock-Taussig shunt, or stenting of the ductus and stenting of the ASD to keep a stable systemic blood flow. Then we have the non-ductal dependent critical congenital heart disease that will require neonatal surgery. Instead of an abrupt loss of the pulmonary blood flow or the systemic blood flow, the PVR drops slowly and there is an increase in pulmonary blood flow leading to congestive heart failure. The baby will have poor feeding, tachypnea, diaphoresis, and failure to thrive. And these are the patients with detransposition of the great arteries, an ASD and a VSD, total anomalous pulmonary venous return, tetralogy of Fallot, truncus arteriosus, among others. Then we reach the point of having 3 exclusive physiological states. The physiology in series, that is the normal physiology in which the PA oxygen saturation is less than the aortic oxygen saturation. Transposition of parallel physiology in which the PA oxygen saturation is higher than the aortic saturation. And then we have the single ventricle physiology or the mixing physiology in which the pulmonary artery saturation is equal than the aortic saturation. What happens in the delivery room with the babies with critical congenital heart disease? We go to the accuracy of the screening fetal hearts. The obstetric screening, even though the OBs are getting better in detecting congenital heart defects, the sensitivity is 37 to 72%. So those are the true positive patients. The specificity 97 to 99%. Those are the cases with the true negative results. So you can see that that sensitivity is not very good if the ultrasound was done by an OB in a community hospital. So you can be set up for a very nasty surprise in the delivery room. If the fetal echo was done by a pediatric cardiologist, the sensitivity and the specificity is a lot higher. So we need to plan the delivery of these babies with congenital heart disease. Why and when are the babies with congenital heart disease sick in the delivery room? Can we predict this? If these babies get sick because of the cardiac situation or because of all the non-cardiac risk factors? And that is a very good question, because we need to know what to expect in the delivery room. Thank God, most of the infants with congenital heart disease do well in the first few hours after birth, because the ductus is still widely open. The patent foramen ovale is widely open. They usually have good cardiac function and good cardiac output. And also the pulmonary vascular resistance is still high, so does not allow for too much shunting or pulmonary blood flow. So why are babies with congenital heart disease sick in the delivery room? So we need to think that babies with congenital heart defects can get they have the usual risk factors for needing advanced resuscitation like any other baby. So the majority of them do not get sick because of the congenital heart defect. They get sick because they can have non-reactive fetal heart rates and they have a hypoxic ischemic event. They can have sepsis, they can have surfactant deficiency, or they are IUGR, they are PI, they have, the mother had PIH, or they have a placental abruption. So they did this study at the University of Michigan, and they analyzed 310 infants with isolated ductal-dependent congenital heart disease, not anticipating to be sick for cardiac reasons, and they found that 75% of them needed intubation or CPAP during the first 2 hours of life, 12% due to non-reactive fetal heart rate, 18% of them due to sepsis, 24% of them due to respiratory distress factor, surfactant deficiency, meconium aspiration, or TTN, or any other factor. So every time that we go to the delivery room to take care of a possible cardiac patient, think that probably that patient is not going to be sick due to the cardiac issue, could get the need of advanced resuscitation because of other risk factors that all the other babies have. There are some exceptions that can give you a hard time in the delivery room, and we need to be ready for that. Poor oxygenation, you have a blue baby that is not changing with oxygen, is not changing with CPAP, is not changing with anything, but the baby looks really comfortable. So he's the typical full-term baby that is a male. It weighs more than 3 kilos, he's breathing comfortable, but he's blue. And probably that baby has transposition of the great arteries. Then you have another group of babies that have severe respiratory distress because they have obstructed total anomalous pulmonary venous return or have hypoplastic left heart syndrome with restricted atrial septal defect. And they are blue and they don't improve regardless of what you do, unless you take care of the obstruction of the pulmonary venous return or you take care of the restricted atrial septum. So in those cases, you need to make the diagnosis fast, stabilize the patient and transfer the patient as soon as possible. Then you will face some patients that get poor cardiac output at birth because they are having SVT or ventricular tachycardia. They have congenital dilated cardiomyopathy or congenital hypertrophic cardiomyopathy. And sometimes you see some of those cases. Airway compromised babies with tetralogy of Fallot with absent pulmonary valve, that they have huge MPA, RPA, or LPA. They are compressing the airway, and sometimes you just need to tube the baby to keep the airway open. So if you are facing one of these patients, you need to be calm under pressure. You need to think, you need to organize your mental algorithm and do the best for the patient. How we make the diagnosis of congenital heart disease? Echocardiography is the key, but as you know, in some community NICUs, or the majority of the community NICUs, when the baby is born, we don't have echocardiography available, and that is a problem. Then, if you are a transport nurse, or you are an ALS, or you are a nurse practitioner, or you are an RT, then what you can do? Well, you go to the chest X-ray patterns, and then you see the typical pattern of the transposition of the great arteries, the typical egg on sling, that you have cardiomegaly with very narrow mediastinum. That's a typical X-ray of the TGA. Then the typical snowman pattern, that is the typical image of a supracardiac TA-PVR. The Carbox pattern that you see in babies with pulmonary atresia and interventricular septum or Epstein malformation, or the typical coil boot that you see in tetralogy of Fallot. Hyperoxia test in a newborn with cyanosis is very useful. You perform it by giving 100% oxygen for 10 minutes, then you measure the after PaO2 and compare it to the baseline PaO2 measure before the test in room air. Usually the baby has pulmonary disease or pulmonary hypertension. The PaO2 goes from 50 to more than 150. The oxygen saturation goes from 85 to 100. If the patient has any type of congenital heart defect, the PaO2 is less than 40, and after 100% is less than 50. The oxygen saturation is less than 75, and then after that, 100% is less than 85. So you have two different types of cyanosis. You have the differential cyanosis in patients that are shunting right to left through the PDA, and you see that the upper part of the body is pink and the lower part is blue. You can have reversed differential cyanosis in which the upper part of the body is blue and the lower part of the body is pink in patients with transposition of the great arteries and systemic pulmonary hypertension, or transposition of the great arteries or coarctation of the aorta. Newborn pulse oximetry screening has been great over the past 15 years, and approximately we save 120 infants from dying every year. We measure the preductal SATs and the postductal SATs. We usually do it at 24 to 48 hours or before discharge, ideally in an infant resting quietly. Use the foot for best screening of left heart obstructive lesions. Use the right hand for the best screening of DTGR or mixing lesions. Sustained pulse oximetry with an oxygen saturation less than 95% is consistent with blue blood entering the systemic circulation. You have a right to left shunt somewhere. So how we identify the newborn with critical congenital heart disease? Murmurs are more often benign at birth than diagnostic of critical congenital heart disease. Visible cyanosis is not present in most newborns with critical congenital heart disease. Using the history and the physical examination alone doesn't yield great results. In the United Kingdom, they did a study and showed that 25% of newborns that were just followed by a history and physical examination with critical congenital heart disease were diagnosed after hospital discharge. So what's the algorithm for newborn pulse oximetry screening? On newborns in the baby nursery between 28 and 48 hours or just before discharge, you do the first screen in the right hand and either foot. Both SATs are 90 to 94, or the difference here is more than 3 to 4%. You repeat another one in 1 hour and repeat another one in 1 hour. And if you get the same result, fails after 3 tests, then you call cardiology for an echocardiogram. If the oxygen saturation is less than 89%, that is an immediate fail and you need to call cardiology. Immediate pass is either SATs more than 95% and a difference between the pre and the postdoctoral of less than 3%. How reliable is the pulse oximetry? The sensitivity for CHD detection is 70%. So true positive cases and true negatives, the specificity is 99%. So positive test is unlikely to be false, but a negative test does not completely rule out congenital heart disease. Which cardiac lesions will not be identified? The right to left shunts. So ASDs, BSDs, or PDAs, not identifiable by pulse oximetry. Why? Because the shunt will not tell you, the oxygen saturation will be normally in the pre-ductal and the postductal circulation, and these lesions are not ductal dependent. If they are large enough and the PVR continue to drop, they can get into congestive heart failure over time after the 2nd week of life. And they might need intervention or medical treatment. Which cardiac lesions will be identified? Lesions that they are expected to have abnormal pulse oximetry. Mixing lesions, right-sided obstructive lesions, left-sided obstructive lesions, and parallel circulation lesions. So low oxygen saturation babies with central cyanosis, the blue baby syndrome, identified by pulse oximetry screening. So we essentially, the mixing bidirectional lesions, they are major connection between the right and the left side of the heart. So you have right or bidirectional shunting in those lesions. So for example, AV canal. The ability of the pulse oximetry screen to identify these lesions depend on the amount of the right to left shunting. If the pulmonary vascular resistance drops too fast, then probably the net shunt is going to be left to right, and therefore these lesions may be missed by pulse oximetry, especially if the PVR drops rapidly. If they are missed, probably in 2 or 3 weeks, those babies are going to be seen by the pediatrician with congestive heart failure symptoms. So what kind of mixing lesions are these ones with bidirectional shunting? Complete AV canal, TAPVR, truncus arteriosus, double outlet right ventricle, double inlet left ventricle, and unbalanced AV canal. Common atrioventricular canal. You see that the expected is a non-ductal dependent critical heart disease. The expected oxygen saturation is in between 75 to 85%. And if the patient starts shunting left to right, they get cardiomegaly and increase in the pulmonary blood flow. Double inlet left ventricle, that means that both atria empty into the left ventricle and the systemic and the pulmonary venous return mix in the left ventricle, in the single left ventricle. So you can have a double inlet with transposition of the great arteries. The expected SATs are in between 75 to 90%. And you can have a double inlet with normal related great arteries, the so-called Holmes heart, rarely ductal dependent unless you have coarctation or pulmonary atresia or pulmonary stenosis. Double outlet right ventricle, both the aorta and the pulmonary artery arise from the right ventricle. You can have double outlet right ventricle without pulmonary stenosis or with pulmonary stenosis and transposition of the great arteries. Expected O2 SAT is in between 75 to 90%, rarely ductal dependent unless you have coarctation associated or pulmonary stenosis or pulmonary atresia. Truncus arteriosus is not ductal dependent. The expected oxygen saturation is 75 to 85%. You have a huge VSD and a common vessel that comes out of the heart and then connects to the pulmonary circulation. If you don't act or you don't recognize these, they get into congestive heart failure fast and the prognosis is very poor. So this is a typical echocardiographic image of a truncus arteriosus. You see a humongous VSD. You see the truncus arteriosus here. And then if you put the color flow mapping, then connects to the PA, the RPA, and the LPA. Truncus repair, they usually close the VSD. They do an RV to PA conduit, and sometimes they need to decrease the size of the truncal valve. If these mixing lesions are getting blue, you need to know that the oxygen saturation in these patients depends on the blue blood that is coming back from the body and the red blood that is coming back from the lungs. They get mixed in that single ventricle, and it's going to depend on the ratio of these two, pulmonary to systemic flow, the QP/QS. Low V. So they can get hypoxemic if the low pulmonary venous oxygen saturation. If you have a low pulmonary venous oxygen saturation, so if the red blood is bluer because on top of the congenital heart defect, the baby has congenital pneumonia, has surfactant deficiency or pulmonary edema, that baby is going to get bluer because the oxygen saturation in the mix is going to decrease. If you have a pneumothorax, the same thing. If you have a pleural effusion of apnea, that will cause hypoxemia. If you have a low mixed venous oxygen saturation in a patient that has decreased cardiac output with this ventricular dysfunction, with anemia, with AV valve regurgitation, then the oxygen delivery to the tissues decreases. If the patient has an increased consumption of oxygen because the patient has fever, is agitated, and is fighting the ventilator, then that patient is going to get more hypoxemic. Let's talk now about the right-sided obstructive lesions. So if you have an obstruction on the right side of the heart, you have pulmonary atresia, you have critical valvular pulmonary stenosis or tetralogy of Fallot, then you're going to have right to left shunting through the PFO, or if the patient has a VSD. Critical valvular pulmonary stenosis, usually you expect an oxygen saturation of 85%. They are always ductal dependent to survive. The right to left shunting across the PFO identifies the critical PS in the newborn infant. You need to stabilize the patient with prostaglandin. And once the baby is stable, take the baby to the cath lab to do an emergency pulmonary balloon valvuloplasty in order to improve the forward flow from the right ventricle. They usually do very well, and the prognosis is very good. If you have a patient with pulmonary atresia and intact ventricular septum, is always ductal dependent. Expected O2 SATs are in between 75 to 85%. You can see here that the pulmonary valve is completely closed. You stabilize the patient with prostaglandin, and then you take the patient to the cath lab in order to stent the ductus, and with radiofrequency opening the membrane, do a balloon dilation of that area, and then stent it and wait for the baby to grow so they can convert that to a 1.5 ventricle. Tetralogy of Fallot may be total dependent, depending on how obstructed is the RVOT and how thick is the subpulmonic area. Usually you have the PSD, a pulmonary stenosis, RVH, and overriding aorta. The expected oxygen saturation is in between 75 to 85%. Sometimes you have the so-called dead pink, in which the pulmonary stenosis is very mild and they behave like a large VSD. These patients can have dead spells, so the patients start crying. They increase the pulmonary vascular resistance, the RVOT spasm, the infundibulum spasm, the right to left shunt increases. The patient gets hypoxemia and hypercapnia, metabolic acidosis. The baby has hyperpnea and tachycardia, trying to compensate to increase the cardiac output and increase the venous return. And you need to break this vicious circle, otherwise the baby will get very sick. Symptoms: the baby gets tachypnic, mild to severe intercostal retractions, anxiety and altered mental status or lethargy, chest discomfort. These babies have chest pain, so the babies with the dead spell cry. They have poor muscle tone during the spells. They get blue, cyanotic, and a very important thing, that the tetralogy of Fallot heart murmur goes away. What are the goals of the treatment? Reduce the RVOT spasm and decrease the pulmonary vascular resistance, increase the systemic vascular resistance. This is to make the pulmonary bed the path of least resistance and decrease the right to left shunt. If the patient has tiny pulmonary arteries, you cannot do a full repair. Then you need a shunt to make the pulmonary arteries grow. So you do a central shunt, or you do a modified Blalock-Taussig shunt, and then when the pulmonary arteries grow, you can do the full repair. The full repair is a patch. You close the VSD, and then you resect all the muscle beneath the pulmonary valve in the infundibulum, and then they were doing the transannular patch. The problem with that was that the patients were left with massive pulmonary insufficiency. And then over time, the right ventricle got dilated. Now the trend is to spare the valve annulus and leave the baby with a little bit of pulmonary stenosis, but not with pulmonary insufficiency. And the results are much better now. Left-sided obstructive lesions, okay? So this means that you have a coarctation of the aorta, you have interrupted aortic arch or severe or critical aortic stenosis. So the PDA is the source of the systemic circulation, is what is going to maintain the systemic circulation. The blue blood is entering the aorta via the ductus, so the pre-ductal SAT may be normal, but the post-ductal SAT will be low. So you will have a baby with differential cyanosis. You have the upper part of the body pink and the lower part of the body blue, and that is the so-called differential cyanosis. So the pre and the post-ductal SATs will be really different, the pre-ductal normal and the post-ductal low. Hypoplastic left heart, that means that we have a very small or hypoplastic left heart. The systemic circulation is ductal dependent, and the systemic and the pulmonary venous return is mixed in the single right ventricle. So it's always ductal dependent. Expected right arm oxygen saturation is 85 to 95%. The expected leg oxygen saturation is in between 70 to 90%. So what's the physiology of these babies with hypoplastic left heart? You have two possibilities. The blood flow that is pumped from the right ventricle can go to the lungs or can go through the PDA to the systemic circulation. So it's going to be a balance in between the PVR and the ASVR. So what's the physiology of patients with hypoplastic left heart syndrome after birth? You see that the blood that is coming back oxygenated from the lungs passes through the PFO into the right atrium, and that mixes with the blue blood that is coming back from the body. Usually the oxygen saturation is 75 to 80%, and that means that probably that the QPQS is 1:1, and that circulation is balanced. So what happens when the PVR start to drop, and these patients start to get in saturations in the 80s and low 90s, that probably means that the pulmonary blood flow is increasing. The baby looks pink, you think the baby is doing better, but very soon that patient is going to get pulmonary edema, metabolic acidosis, and poor cardiac output. So you need to keep these babies with an oxygen saturation in between 75 to 85%, so you can keep the QPQS as close as 1-to-1 that you can. So what happens in these patients when the PDA closes? So these patients go into shock. So the systemic circulation is not maintained, and if you don't reopen the PDA, that baby probably is going to die. So once you stabilize the patient with prostaglandin, if the patient, you transfer the baby to the hybrid suite so they can do the stage 1 procedures, palliation. And this is a suite in which the surgeon and the interventional cardiologist work together, and they can do surgery and they can do intervention in the same room. So first, the surgeon opens the chest and puts the RPA and the LPA banding. Once he finished, then he helps the interventional cardiology to do the PDA stenting and the ASD stenting. So you can see how the PDA stent is placed, so you can maintain the systemic circulation, and the atrial septum stent is in place, so you can have a good mixing in between the left atrium and the right atrium. So in that way, you restrict the pulmonary blood flow, put in the pulmonary artery bands, you keep the systemic circulation going with a stent in the PDA, and you have a good mixing in between the right and the left atrium with the stent. So you finish, in this case, the hybrid stage 1 palliation, in which you have the pulmonary artery bands that limit the pulmonary blood flow. You have the stent that is giving you stable systemic circulation, and you have a stent in between the right and the left atrium, so you have a good mixing. So size doesn't matter then. You can have a baby that weighs 1.1 kilos and they can do the first stage palliation without any problem. So this baby got the bands, got the PDA stent and the ASD stent, and as you can see, is doing very well. Then in 6 months, you do the hybrid comprehensive stage 2, in which they do the reconstruction of the aortic arch. They take the bands away, they repair the RPA and the LPA, and yet they connect the SVC to the right pulmonary artery. And by 2 years, they complete the Fontan procedure. They finish the palliation for the hypoplastic heart syndrome. The left-sided obstruction is the critical coarctation of the aorta. Is always ductal dependent. Expected upper extremity SAT is 90%, expected lower extremity SAT is in between 60 to 85%, and you have differential cyanosis. The upper part of the body is pink, the lower part is blue, and you need prostaglandin to stabilize this patient. They usually have associations, another congenital heart defects. If you have a baby with a large membranous VSD, you need to think about coarctation. The association is very common. If the patient has hypoplastic heart syndrome, probably has coarctation, aortic stenosis, thrombosarteriosis. Double outlet right ventricle is associated also with neonatal coarctation of the aorta, or patients with Turner syndrome. So what happens if you have a baby with a PDA open and has coarctation of the aorta? The pulses in the upper extremities are normal. The pulses in the lower extremities probably are a little bit weak, but almost normal. Postductal SATs are normal, the urine output is good, and the baby is not acidotic. If the PDA start to close, the pulses in the upper extremities are normal, in the lower extremities are weak. Postductal SATs start to be low, good urine output, and the patient is not acidotic. But when the PDA closes, the pulses are normal in the upper extremities or even prominent, and they are absent in the lower extremities. The postductal SATs probably are, you get a poor trace. If you get a trace, they might be normal if there are some oxygenated blood going through that, the patient is oliguric and is acidotic, and you need to reopen the ductus with prostaglandin. This is a typical CW Doppler of the descending aorta that have this double contour and the diastolic flow that is very typical of coarctation of the aorta. And then if you do a CW in the abdominal aorta, you see the difference on the trace. So it's damp in the abdominal aorta. So prostaglandin administration is the best way to stabilize this patient. If you use a high dose, you see the so-called migratory polycyclic eruption in this patient. If you decrease the dose to 0.05 mics per kilo per minute, then that rash disappears. If you do the lower dose, the baby doesn't have apnea. Usually they get apnea if you use doses above 0.15 mics per kilo per minute. They can have fever also. That doesn't happen if you use the lower dose. Once you stabilize the patient, you transfer the baby for surgery. And the typical surgery is they close the PVA and they resect the quartated segment. The end-to-end anastomosis is the best repair and is the technique that has the less frequency of requartation over time. Interrupted aortic arch is always ductal dependent. Expected right arm oxygen saturation is 98%. The lower extremity oxygen saturation is in between 40 and 60. They need to reconstruct the arch. They are different types, type A, B, or C. A is after the interruption is after the left subclavian artery. B is after the left common carotid artery, and C is after the innominated artery. Then we have the parallel circulations. And the parallel circulation is the transposition physiology. You have the aorta is coming out the right ventricle, so the blue blood is coming out of the heart through the aorta, and the LV is sending the red circulation back to the lungs. And if you don't have a communication in between the chambers, that baby is going to get very sick. You can have reverse differential cyanosis if you have a patient with transposition of the great arteries with pulmonary hypertension or coarctation of the aorta. And that means the baby is blue in the upper part of the body and pink in the lower part of the body. The transposition of the great arteries is always ductal dependent. Expected to the right arm oxygen saturation in between 75 to 85%. The lower extremities in between 80 to 90%. Typical image of great vessels coming out of the heart in parallel. The aorta is coming out the right ventricle and the pulmonary artery is coming out the left ventricle. And then on the long axis view, you see the left ventricle and the PA is connected to the left ventricle and it's going down and bifurcating there. What is the physiology of the DTGA? So survival depends on the intercirculatory mixing at the level of the atrium ventricle of the great vessel. So the volume of blood shunting right to left must equal the volume shunting left to right in order to have a normal cardiac output. So if you have a patient with DTGA and an atrial septal defect with atrial mixing alone, and the mixing is good, you have a bidirectional shunting. The right atrium to LA shunt should be equal to the LA to RH shunt. So these patients usually have moderate hypoxemia and no congestive heart failure, and they usually do well. If you have a patient with DTGA, ASD, and a PVA, then the effective pulmonary blood flow is the flow that goes from the aorta to the pulmonary artery, and the volume of shunting from the left to the right atrium must be equal to the shunt going from the aorta to the pulmonary artery to keep the cardiac output okay. They have excellent mixing and they are only mildly hypoxemic, but they will get in trouble with congestive heart failure very fast. And the other problem is you have low diastolic pressure. The coronary artery is feeling diastole, and sometimes the coronary artery pattern is not completely normal. What happens if you have a small PFO or a small ASD? You are giving prostaglandins to increase the mixing in the LA, but if you have a tiny hole here, you are going to increase the pressure in the left atrium, and that patient is going to get pulmonary edema and very soon metabolic acidosis and poor cardiac output. So if you have a baby with a small PF or ASD, and you are giving prostaglandin, you need to think about that. Prostaglandin increases the left atrial mixing volume secondary to atrial mixing. If the ASD is restricted, you need an atrial septostomy as soon as possible. Transposition physiology. You don't mix at the PDA. If you open the PDA with a prostaglandin, you increase the flow that comes back to the left atrium, and indirectly you increase the mixing. But you need to have an ASD to be able to do that. So at some time you will need an atrial septostomy. You have different sizes of balloons. You can do the balloon atrial septostomy on the fluoroscopy in the cardiac laboratory, or you can do it at the bedside, guided by ultrasound in the NICU, equally effective. Preoperative brain injury is not related to the atrial septostomy. It depends on the oxygenation and the time to surgery. The longer the baby is hypoxemic and the longer that people take to take that baby for surgery, you can cause brain injury faster. So what you can do if you can't do an atrial septostomy, but you have a good size ASD, you can increase the pulmonary edema's return to the left atrium with oxygen, with nitric oxide, or alkalinizing the blood, and using prostaglandin. That increases the ILA volume and the pressure, increasing the mixing. But remember, only if the baby has an ASD and a PFO of good size. Once a patient is stabilized, then you transfer the baby for surgical correction, and is the arterial switch operation, that one that essentially cures these patients. So, from all the critical congenital heart disease, probably having the transposition of the great arteries with intact ventricular septomies, if we can say that, is one of the best, because you have a corrective surgery that, even though has its pros and cons and its complications compared to other ones, this is probably the best to have. So let's go to 3 cases. The case of the ventricular septal defect, the typical course is the murmur develops after the PVR falls, and it sometimes takes days. Symptoms: congestive heart failure by 4 to 6 weeks of life. Elective surgery, if the baby is failing medical treatment, is at 4 to 6 months. What do you do in the delivery? Usually, these babies can be delivered standard delivery, normal postnatal care, echo and cardiology consult prior to discharge to establish care. Case number 2, prenatal diagnosis of hypoplastic left heart. Induced delivery at full term, immediately taken to the NICU team. PG started, umbilical lines placed, and admitted to the cardiac ICU. We need to remember in the delivery room that the PDA is open, the PVR is still high, should be at hemodynamically stable. The goal of oxygen saturation should be more than 75%. It's okay to give supplemental oxygen if the baby is having surfactant deficiency or other things. If the baby is unwell, probably it's not cardiac. Just remember that they can need advanced resuscitation because of other factors. If the baby appears well, encourage parental infant bonding without a prenatal diagnosis and before the area of pulse oximetry screening. These babies often look well enough to be discharged home, and they come 7 days later to the emergency room in shock. Hypoplastic left heart syndrome, ductal dependent, is a ductal dependent systemic circulation. Shock developed with PDA closure. PVR is still high, so the lungs don't flood. They need neonatal surgical palliation or intervention during the first week. So standard delivery, initiation of cardiac care in the first few hours, and ICU admission. Case number 3, the transposition of the great arteries. Ductal dependent for adequate mixing. Atrial septal defect critical for adequate mixing. May need urgent cath for balloon atrial septostomy. Neonatal surgical repair in the first week. This is the typical critical congenital heart disease. So you need to stabilize these patients as soon as possible. If you're a transport nurse, you need to keep your cool, do everything you need to do, and transfer the baby to the cardiac center as soon as possible. And the most important part, just remember, you need to be calm under pressure. Don't freak out. The majority of these patients do well during the first few hours of life, and you have time to think and organize what you're going to do with these patients. Thank you very much for your attention. Any questions? Any?
Dr. Fernandez, I had one quick question.
Yes.
I have heard from one other neo, if you're not sure of the cardiac defect, to go ahead and start PGE, even if it's a TAPVR. What are your thoughts on that?
If the TAPVR is obstructed, you need to, and you don't have an echocardiographer or a pediatric cardiologist on hand, the only way that you can know if the baby is going to improve is just starting the baby on prostaglandin. If you have nitric oxide, start nitric oxide. And then if the baby is not getting better, you're getting your answer there. Okay. So if the baby, instead of getting better, is getting worse, the image is of completely white out lungs, and the baby is not improving with anything, then at that moment you can stop that.
Okay, thank you.
Any other questions for Dr. Fernandez? Okay, well, thank you, Dr. Fernandez. It was a very interesting talk and I really appreciate it. I appreciate you doing this for us. So go ahead.
That's a pleasure.
So if you're on here and you're wanting to get CEs or you just want to give a review of the lecture for Dr. Fernandez for feedback, go ahead and open your camera and hover over the QR code, then click on the link to the survey that pops up. If you don't have your phone, write down the link and enter it into your search bar. The QR code will be sent to you directly to your, the survey will be sent directly to your phone. And then as you enter your email, the CEs will be sent directly to your email. If you have any issues, please jot down my email and feel free to contact me with questions. Once you're done doing the survey, you can go ahead and jump off of the group. Patricio, you can jump off now if you'd like.
Don't okay, thank you, Denise. Have a great day. Take care.
Hi, everyone. I can see that for some reason the name change did not occur on this survey, but go ahead and fill out the survey knowing that you're using this one, and I will adjust it and file the results under the appropriate lecture. So thank you. It looks like all of the questions are correct for Dr. Fernandez's presentation, and I'll just change the name of the listed on there because the top of it says recognition and stabilization.